This is a massive jump, 70% jump, comparing 2022 to 2018, where there were just 150,000. So you can see that countries are putting a lot of effort in training what? More health workers. But one thing, 6 countries are the top producers, and those 6 countries are those who are really driving this massive increase. The DRC, Uganda, Ghana, Ethiopia, South Africa, Nigeria, and Tanzania are the top producers. So these are the ones that are particularly the DRC. Also, we see the private sector is contributing a lot more, putting in money to train health workers because they want to make profit from the training. So that is also influencing the expansion. But when they come to the absorption, the recruitment, they are doing 22%, not matching the 40% that they are putting in the training. So the public sector would plan, like Dr. Percy was saying, try to control the production so that they can absorb. But if the private sector is driven by profits, they will produce more and then hope that the government will take. Eventually, what we have in our hand is unemployment. And you will see that pretty soon. So that takes me to the issue of what is the total stock and supply in the region. As of 2022, our last count shows 5.1 million health workers in Africa, here referring to the 47 countries WHO support in the African region, which is an increase over 4.3 million in 2018 and 1.6 in 2013. You can see a massive improvement. And this is how they were distributed. A little over 550,000 community health workers, more than 330,000 doctors, 1.7 million nurses, 17,000 plus pharmacists, 25,000 dentists, among others. If you were to pick this across different countries, here using 5 occupations, doctors, nurses, midwives, pharmacists, and dentists, because for these 5, the data was consistent for all the countries, so it was very easy to put them together and compare. This is how the improvement has taken place over time. You can see South Africa, for example, because we are here, let me mention that, has improved slightly over time. But you will soon see that improvement can't disappear if more is not done. So this is looking at the quantity issues. So of the 5.1 million health workers we have, what do we know about the quality? I am sorry, but I don't have good news on this one. There's been big studies that has been done. For example, across 11 countries in Africa, and looking at more than 16,000 health workers were given clinical scenarios. You read the scenario, you provide your thought thinking about the diagnosis and treatment, and they compare with what is the standard on paper in terms of national policy. What was found is not very good. 60%, most health workers got 60% of the diagnosis correct, but 35% got the treatment right. Put the other way, health workers will not get 40% of your diagnosis correct and will not get 65% of the treatment right. Is that not scary? Do you need further explanation why 48% of people access health services and they die of poor quality? So we can now begin to draw the conclusions. The study also found further, having more academic degrees does not add much to the competencies. So having a lot of chain of degrees, you write your name, comma, PhD, MSc, MPH, M. all of those ones do not add much. Again, younger people tended to be more competent than older ones. Are you happy with that one, young people? So this reflected something, that maybe there's an improvement in something, either in curriculum or the way the people are now taught, or maybe the use of technology. However, that pace of improvement to lead to 10% change in the quality of services will take us 25 years. So it's so small that we can't rely on that level of improvement to become better. Another study, which involves 79,000 health workers, also across 10 countries, and here they actually ended up even reviewing patient records to confirm things, found one thing. In all our effort to address the lack of competencies, we ended up taking health workers from their duty station. So there was a 35% absenteeism rate among the health workers, but only 4% were truancy. The rest were people who had been sent to go for training, to go for that. And so more or less they were authorized absences, but they ought to have been at work at the time that they were not there. This same study also found that when they come to treatment accuracy, it's 56% in terms of diagnosis, and 68% of health workers would usually get your diagnosis treatment, your diagnosis about 50% or less. Again here, the public sector tended to do better in identifying common illness and treating them well compared to the private sector. The private sector is usually better when it's a complex case, you go and see the big consultant specialist or something. And rural areas tended to pay more attention to the patients compared to even urban areas. So here again, telling you about attitude, about competencies, among others. Just some of the issues that Dr. Percy was mentioning earlier. The next one I want to talk to you about is migration. We have a bucket now. We are training and putting in. You know how many are coming in from training, and we know their competencies in that bucket. And now let's look at the leakages. In Africa, 1 in 10 of our doctors and nurses that we have trained are already abroad. It's not that they are on their way, they are already abroad. 1 in 10. What is more worrying is that in the last 3 years, we've done large surveys among health workers, and we have found one thing. 42% of the health workers currently available have intention of migrating one day. 42%. So this tells you that people want to go. Why they want to go? The obvious, you know it. But now one thing is this. When we look at the countries they prefer to go, for English-speaking countries, it's typically the UK, tops at number 1, followed by the US, followed by Canada, followed by Australia and New Zealand. Then for French-speaking countries, the obvious, France, Canada, typically. Then we see a new dimension of people wanting to go to the Gulf countries, and Dr. Percy is one of the experts in that area globally with migration, so he has all the figures. But one of the things that we have come to realize is that if you go to Europe, their doctors, you have a lot of them who are retiring soon. 30% of doctors in Europe and 20% of their nurses are at the verge of retiring in the next 5 to 10 years. Their education system is insufficient to fill this gap and address new demand that will come from the population. It's even more expensive to train and then employ. So they rather spend their money to employ straight from where they can. That means they will pick the best from our countries. So the best here are not necessarily the new graduates. They would usually pick those who are well experienced, are specialized, and those things. So migration is not going away. It has been with us. It will be with us. The earlier we agree that we need to make interventions to address and keep enough for ourselves, the better. Or if we want to train more and send some out, we make that decision also the better. And for every doctor that leaves our shores and every nurse, we lose more than $1 million. Approximately $2 million for doctors and 1.2 for nurses. With all the money they send back home when they work there, it does not offset this loss to the country from which they were trained, from primary school to when they qualified as a doctor or a nurse. So data. And so our analysis from these 10 countries where we have showed that unemployment among the health workers is approximately 27%. Approximately 27%. But put it in real human beings terms. 118,000 health workers were trained, skilled, available, but they had no jobs. This number is now roughly 200,000 in Ghana, with USAID scrapping jobs, and so people become unemployed, and 2 badges have completed 25,000 per year. That is now a huge number. Look at Zambia. Is there Zambia here? 46,000. So these are not small numbers of people, young people who are trained and not employed. You should know that nurses, because they are the majority, they are also the majority being affected when it comes to the unemployment. So more nurses are unemployed compared to doctors. When they were developing the South Africa HRA strategic plan, the analysis at the time showed that 45,000 people who identified themselves as having skills in health were still looking for jobs. This majority of whom were nurse aides, right? Nurse aides, yeah. I believe by now these numbers have changed, but it tells you that a lot of effort is needed to address the issue of unemployment. So somehow we can't blame our young people for wanting to travel abroad. But it is the who travels that is the issue. Because it is as a biased selection of the experienced and the specialized. Now, Professor Mabunda, if I didn't show any projection, you would say I refuse to address the topic you gave me, so I've been giving you a few numbers on those ones. So in the African region, what we have seen is that this is across the 47 countries. The number of health workers we have are increasing over time. That is this blue line. If you project it over 2030. The details are published in a paper, so the paper I showed it in the previous slide, so those of you who can read the details from here. This is a big report that has everything. This is a paper summarizing it. Yeah, you can look at the details there. Then when we look at disease burden, we looked at 118 diseases and risk factors that either kill people in Africa or make them fall ill. And country by country, we look at what is the prevalence for that country. The minimum estimate, the maximum, and then the median estimate for each of those diseases and risk factors. Then we look at interventions that must be delivered to address these risk factors, and by whom. And we look at how much time each worker will spend to deliver that intervention, and we modeled out how many workers are required. This is what we found on our base scenario for Africa. If we were to look at it, say, assuming all the disease prevalence becomes low, if our health promotion and disease prevention works, what will happen? This is the numbers required, right? Then assuming that nothing works and the diseases increase to the highest point, what will happen? These are the numbers required. So you can see for Africa, any scenario of the disease burden requires more health workers because the projected health workers is the blue line, is below each of these scenarios. So whatever the case is, the argument is always good to invest in different areas, health promotion, disease prevention, among others, but it does not yet replace the need to train more health workers. We haven't gotten there yet. I will show you a few countries that their blue line crosses one of these scenarios. And you can say for these countries, they need to begin to think about optimizing. Here, as South Africa, we need to optimize, but we just need to train a bit more. So our projections show that in 2022, Africa had a shortfall of 5.6 million health workers, and by 2030, that would increase, given our population growth and the shifting pattern of diseases, to 6.1 million shortage of health workers. About 52% of this shortage will be for doctors, nurses, midwives, pharmacists, and dentists. There are lesser talked about occupations that the shortages are bigger if you look at it in terms of relative terms. Like if you go to physiotherapy, you go to laboratory science, those ones. We don't talk about them much, but the details show that those ones, we even have a bigger gap in terms of, in relative terms, in the percentage of the shortfalls. So think about this one now. Each country put in the graph, comparing their worker density. Their density is how many workers you have per 10,000 people, and also your graduates, comparing your graduates with also the need to have more health workers. Struggling in everything. They don't even have enough capacity to produce. So for them, their shortages are huge. They don't have the capacity to even fill it. Category 2, they can train more, but the problem is that they can't absorb them. Category 3, where South Africa is, they have relatively better number of health workers now, but their level of production will not be able to maintain that number over time. So take note of that. That's where South Africa belongs. Then category 4, they have reasonable numbers. Their level of production is high. Their problem over time would be massive unemployment. So now I want to compare South Africa and Kenya who are here, and compare also Ghana and Zambia who are here, so that you can see how it plays out in all this modeling. This is Kenya. Look at their blue line, that their workers projected over time is almost flat. Because the numbers that are leaving the system through retirement and migration is almost equivalent to the number they are producing. And the fact that they are also not absorbing much. And look at the different scenarios of numbers required to address their disease burden. They have no scenario to be able to what? Meet those ones. So this is not a country to focus their attention only on optimization. You need to increase and optimize. This is South Africa. South Africa's situation is a bit more dire than Kenya, actually. And I will explain. Because South Africa has what is required to meet at least the minimum service, the minimum scenario. You can see your blue line is above the minimum scenario. But your numbers are reducing over time instead of increasing. And over time, it is at risk of getting lower than the minimum scenario. You know why? According to data from the South African Nursing Council, you had a reduction in 2022, the register reduced by 6,870 nurses. For different reasons, we don't know. Whether they migrated, they retired, or we don't know. Now, if you compare 2020 to 2022, you are having about 14,000 reductions. That's a massive number to decrease in one country. Now, to go further into South Africa, you would notice that 19% of South African doctors are 55 years or more. So they will retire in 5 to 10 years. They don't retire because they go to the private sector. No, but this is the thing. The life expectancy of South Africa, even when you adjust because they are well paid among others, is such that the incidence of long-term illness will come in, and with time, whether they like or not, they have to reduce how much they can work. So the earlier South Africa plans to replace them, the better for everyone. But now take a look at it. Overall, if you add those who are retiring plus those who migrate, South Africa is losing roughly 2.3% of its doctors per year, but it's replacing it by 2.1% from their training pipeline. So there's a small fraction of a loss each year you are beginning to accumulate. So with time, that can potentially have a reduction in the total number of doctors you have. But it's worse for that of the nurses. 24% of the nurses are either 55 or more in terms of age. Retirement is projected to be around 1.9% per annum with 0.1% annual immigration. That's together about 2%. And that is simply because these days South African nurses are not too keen to move like the other countries. So I think they are basically now focusing more about the UK, the US, and a few others. So not big numbers like you would find maybe in Zimbabwe and others. So for nurses, it's a total of 2% loss per year, but your replenishment is just 0.8%. Are we together? So yeah, I've pulled the 4 occupations here for you to see: the nurses, those who are near retirement, doctors, pharmacists, and dentists. Look at dentists, 25% of them are 55 or more. Now, so does it now explain why this line is dropping in South Africa? The blue line, your projected numbers. You getting it? The production is below the attrition. In terms of money, because of this, any intervention that you make is not cost neutral. It requires money. In Kenya, in 2022, we did this analysis and we told them that, you know what, guys? This red broken line here is the total amount of money available in the country to employ workers from both public and private sector. And the black line is the cost required to pay the current workers and employ those who are trained. Kenya has a gap. That gap is quite small. You can see the gap between the red line and then the black line. That small gap alone is accounting for more than 27,000 unemployed Kenyan health workers. In fact, in Kenya, I know doctors who are not employed. In Ethiopia, I have been driven in a taxi by a doctor, an unemployed doctor before. So these are not like statistical analysis that we are just saying. They are things that we know the people who are affected. Look at Ghana. It's my favorite example because anytime you are looking at labor market failure, Ghana is a classical example. By the way, that's where I come from, so I know them too well. So their blue line is rising very sharply. You can see that across that moderate scenario in terms of need and almost threatening to reach even the maximum scenario. Ordinarily, this would be good news for the country, isn't it? But you saw earlier, they've accumulated 118,000 unemployed doctors and nurses and pharmacists. So that is not good news either. Look at Zambia. Their blue line is rising quite remarkably and threatening to already meet what? The minimum scenario for their need. They are far from the medium and the maximum scenario, but at least they are crossing the minimum scenario. They are one of the countries with impressive what? Growth in terms of the workforce accumulation. But you saw 46,000 what? Unemployed health workers. So the question is, in these countries, is it better to train and they are unemployed, or is it better not to train and so that you don't have an unemployment problem? I don't have the answer. But I do know that in COVID-19, when Ghana needed to recruit more workers to fight COVID, they recruited 40,000 in 2 weeks. That's because they had unemployed nurses. If they didn't have, they had no chance to import them from abroad. So this is the Ghana situation. We warned them actually in 2020. We did warn them that you were getting to a point where you will not be able to employ workers. Somehow they thought it was just mathematical modelers sounding the alarm bells when there's nothing. But unfortunately, it has come to pass. You see the situation in Zambia, they started messing it up from 2022 between the red and the black line. So that increase you are seeing there, it's not like the Kenyan situation. If you look at the Kenyan situation, we had a circumstance where Kenya could potentially be able to absorb all their health workers. That's this line where they cross, the blue and the red, the black and the red cross. In Ghana, we don't have that scenario. That doesn't exist in the context for Ghana, because the black is rising fast and the red is almost steady. The red is how much money the country has to employ workers. In Zambia, they are like diametrically opposed. There's no way they are getting close to each other unless a decision is made to increase how much is spent on health workers or reduce how many they are training. So this is how some of the labor market analysis can give you current information and forewarn you about what's likely to happen in the future to give you the chance to take corrective actions. Really, for all the countries, we are spending more money on health, but how much health is a priority on government budget is remain the same. So when they tell you, oh, health is our top priority, yes, it is a nice rhetoric, but in reality, they are not allocating more money for health. So don't expect too much. Worst of it, the graph on my right is how much governments are owing in terms of debt compared to the total value of their economy. That debt is increasing for all countries. So we are getting more debt to pay, and therefore less money to spend on social services that include health. To put that in real numbers, you can see this. This is how much African countries are spending on health. South Africa is one of the top spenders on health. It's about the second highest top spender in Africa. Most countries are below even global averages that are needed to make progress on the SDGs. South Africa somehow is spending what is reasonably good enough to make progress on the SDGs. So that's why I say, Dr. Percy said the truth. I will put a number on it that you need to look at what efficiencies. In terms of how much of the health budget is going to health workers as salaries, overall in Africa, 43% of every money spent on health goes to health worker salaries. Globally, it's about 57%. Here again, you can look for where your country is and then see whether you are doing more than the average on West South Africa. Close to 57. So here again, in terms of prioritizing how much is spent on health to pay health workers, South Africa prioritizes that more than most countries in Africa. It's almost at the level of global. And remember, when it comes to how much you are spending on health, you are also above Africa. You are close to, not really global, you are close to the big countries. So that means that it's a question of prioritization, and I'm coming back to that one. In Africa, if we were to employ all the workers we have trained who are not employed, we need additional 43% of our budget. 43%. South African numbers are also there, but I don't have it here. It's in one of the papers I showed earlier. You can look at the South African number. If we wanted to reduce the shortage of health workers in Africa by just half, we need to put in 77% more on the budget. So the question is, can we easily tell Treasury to give us that money? For you to decide how to tackle the argument with Treasury, we have looked at how the countries are prioritizing their health and their health workers. Country group 1, for them, the health sector is getting too little from the national budget, and health workers are getting little from their health budget. So for them, they can argue to get more. Group 2, they are prioritizing a bit more on health, but less for health workers. So the money is going to other things than worker salaries. Then group 3 is the opposite of the group 2. They prioritize more for health workers from so little they are getting from the national budget for health itself. That means they'll have little to buy the medicines and among others. Then in group 3, they prioritize enough or more for health itself, and from there, they also prioritize more than the regional average for health workers. And this is where South Africa is, for that group 4. So in group 4, the best way to increase your ability to spend is to look at efficiency gains. So Dr. Percy just said it. I only put the evidence to what he said. Is to look at more efficiency gains than to say, just give us more money. So as I conclude on this, the labor market failures in Africa are characterized by having what? Fewer workers than we need. We have a shortage of 6.1 million. But at the same time, we have a paradox of unemployment, where 27% of health workers, trained, skilled, are not employed. And this is being exacerbated by, or that one is exacerbating, migration to high-income countries who, due to COVID-19, have woken up and they want to fill more positions because recruitment is cheaper than training and recruiting. This analysis has been done for about 24 countries now in Africa. Those that you see on the screen are available online. You can download them. The others are not yet available online. I would encourage South Africa to dig deeper into its workforce situation by doing a labor market analysis. I would highly encourage that. And maybe Prof. Mabunda and colleagues, something we want to take as a research project with Dr. Percy. Now, this is just diagnosis. If you diagnose, what do? You need to find a solution. We think that so there was a charter adopted in 2024 called the Workforce Investment Charter, which was adopted in Windhoek, and thanks to South Africa for strongly supporting it. The charter says that when you do the evidence generation like this, have a dialogue between the Ministry of Health, Labor, Finance, and the regulatory bodies, professional associations, all of them, to agree on where to go as a country. And when you do that, do a joint planning, like South Africa already planned to do. Have a joint plan on what we are going to do with every partner or every stakeholder having their role very clear in that joint plan. And beyond just a plan, let every partner commit formally to their role by signing a memorandum of understanding, a compact, whatever name you give it in the national context, so that you can hold each other mutually accountable. And this, we should focus on having more investment in health where appropriate, in education, in jobs, but ensure efficient use of the resources that you have, and then ensure accountability. All of these are things Dr. Percy already mentioned. I've just put them in this framework for you. So Zimbabwe is one of our test countries that has done this. All of this process I talked about. They did a labor market analysis in 2022, did their joint planning to have a national strategy also in 2023, And from there, they agreed, picked out the things that require investment and developed a workforce investment plan. And that plan went to cabinet approved it, and they signed it officially as a compact between education minister, finance minister, labor minister, health minister, and there's another one, I forgot. There were 5 ministers on the side of government. And on the side of partners, the different stakeholders in the country, including the Global Fund, USAID, WHO, UNICEF, we also signed it, and then we have a mutual understanding of what our roles are and what we are going to put in. And so they now do a meeting every 2 months to check whether you have done your part and whether one has done their part. In this compact, the government promised to add $166 million of investment annually in the health workers. The Global Fund put $30 million for 3 years. I've forgotten what the other partners did, but different partners put in some amount, and they are tracking that. So they are implementing this. It's ending in 2020, end of 2026. We'll see how much progress they have made, and then what you can also learn from it. So as I thank you to take my seat, the issues are many. We need to invest more in the training of health workers and employing them. But more than that, we should spend more energy also to transform our education to be competency-based to address the quality issues. And to do so, we should focus on using evidence to inform our planning, our decision-making, our dialogues, and eventually we shall not remain the same. Thank you so much. If you are pleased with, please champion that we should invest more in health workers. Thank you.
I did know you were going to do it, going to clap for him, although I haven't said that. But if we were listening, really listening, these are preachers. They've preached by Teti njalo. Anti kunjalo? By Teti njalo. Now they need us to ask them some questions so that they can answer the questions. But before I can give the mic to the audience, let me understand if Dr. Angel is online. He's also part of the panel. Dr. Angel, are you online? Okay. At the moment, I'm handing over to the audience to have some questions to the panelists. I won't summarize or do anything because of time, but what I can say is I was having a question to Dr. Bayeni about the NPT, the NDP 2030, of what has happened in these 5 years. He has explained it thoroughly and very well. I won't do that. But now I'll hand over to the audience to have some questions to our panelists. I've got so many hands, and I'm going to limit them. The ones I'm seeing now are the last ones. No more. So the ones I'm seeing, let you have the count. I'll start there at the back. 1, 2, 3, 4, 5. Coming down, 6, 7, 8. We start here from the front. Over to Dr.
Thank you very much. Zianda Mgugudosello from the South African Medical Association. I actually have a question for each one of them, but I'll just limit it to 2 questions, if that's okay.
Please.
Thank you. Thanks, Dr. Asamani, thank you for your presentation. Efficiencies are a big thing, and I think we're very clear as the South African Medical Association on how we need to improve efficiencies in our health system. So on to Dr. Percy and Dr. Luvuyo then, talking about efficiencies, 2 things I picked up. The first one about the unemployed doctors. We have about 1,048 of them that actually filled a survey, and 93% of those want to work in the public sector because that is where they get trained for specialty posts. So then my question to you is, in thinking about doing things differently, has the National Department of Health explored training these specialists in the private sector? So that's my first question. The second question is on the issue of overcrowding that you raised. Leveraging on the telemedicine as well as the virtual consultations that have been mentioned throughout the day. What has the Department of Health done or thought about utilizing the current human resources and even human resources outside the province to offer services to the 85% public sector patients that require them? Thanks.
To save more time, let the doctors respond on that. Is Dr.
Yeah, quickly on the one of training specialists in the private sector, it's already happening. I mean, the ophthalmologists, quite a number of them are trained in the private sector. I think it's a matter of ensuring that there is proper MOUs in place, I mean, the Pretoria Eye Center, I know that it actually does a lot of that. Around, yes, I would agree that people want exposure in the public service for purposes of training. But if the seniors are not there, who's going to train them? That is why then I don't think it's a chicken and egg, but almost that's why we've got to deal with those efficiencies. Around telemedicine, maybe Dr. Bayeni would talk about it, but so far I think the evidence has not been that good, in our country in terms of using telemedicine, as a mechanism. But he's more recent from clinical service. I left clinical service decades ago.
Thank you, Doc.
Thank you. No, I think the experience that public sector has had was to probably just want to rush and mix the issue of telemedicine. But if you listen today, there is a different approach we can explore, which is to say, let's start and explore with specialist services. Because in any case, if you consider the example that was made, those patients that are going to travel for oncology services are still going to meet the same specialist or the same cohort, but that cohort can consult them where they are. Instead of wanting to make it replace, or we think that it's going to replace general practitioner work or something. So I think that's where we might have missed it a bit when we were, because it's not a new concept in South Africa. Even here in Eastern Cape, at some stage, we had a demonstration of linking Cecilia Makiwan with Butterworth, saying that we are promoting telemedicine, but that has since died a natural death. So I think as long as we can have a different approach to say, maybe let's start with specialist services and let's be specific, which ones do we want to start with, and then we can see if that cannot give us the value add that we want. But the experience, unfortunately, from the public sector was, if you look back now, you say how much we've invested before and where are we now? Some of those gadgets are not working, some of those connectivity are not there. So we need to just make sure that this time around we are proper in terms of project management. Thanks.
We can continue with the questions. Here's a hand.
Thank you. I'd just like to thank all the speakers. The conversation and the presentations were very engaging. My question is for Dr. Bayeni and Dr. Percy. I'd like to start by saying that I've heard your presentations loud and clear, and I quite understand what you've said. But everything that's been said, I still have certain things that need clarity, just like any human would. The first thing is, have you considered clinical associates in your workforce planning going ahead? Because we know that, I think, looking at the Eastern Cape, the last time that clinical associates were hired was in 2021, and that was 18 out of a class of plus minus 50. Since then, we have had zero employment within it. And I do understand the reasons why. But it begs me to think about whether, what I'm trying to do is gauge whether clinical associates do have a future within the public sector. Thank you.
Okay, then the second question. There's the hand.
Good afternoon. I am Womgazi Majeke, Dr. Majeke, currently working at the Public Health Department in the Walter Sisulu University. Thank you so much to our presenters. I think I've learned a lot today. It has all have been eye-opening. But my question, I had a lot of questions, but I've just limited it to one. It's not even a question really, it's for Professor Jan, when he was speaking about financial protection in cancer care. It was just to highlight an issue that we're having in our region, that most of the out-of-pocket payments that are done by patients who are diagnosed with cancer, it's through accessibility or traveling. Some of them travel for 5 days from district hospital straight to the tertiary facility or oncology unit, and then they need to travel back, and some of them need to be accompanied. So that is breakfast, lunch, and supper for multiple people. And also their comfortability in terms of where they sleep, how they are accommodated. It's still a very sore and painful issue for us as healthcare workers to see. So I just wanted to highlight and ask if is there any plan in the future after we are done with the project we're currently doing now to do sub-studies or to expand on cancer care, especially looking at the district hospitals instead of screening and referral. Thank you.
Thank you. That's a third hand. And the fourth one, behind you, sir. Behind you.
Good afternoon. Thank you very much for the opportunity. There has been highlights, I think, from Dr. Jan on the issue of corruption, that one of the things that are frustrating the healthcare industry is the issue of corruption. And Dr. Baeni also mentioned on point 4, on point 4 of their five goals, one of them is accountability of those who are in government or who are in leadership. I think it says the optimal governance, ensure optimal governance and build capable and accountable strategic leadership in the management and management in the health system. What have you done to eliminate the corruption that is the one that is actually costing the healthcare industry? What has been done to eliminate the corruption and to hold the leadership that is responsible for the corruption? What have been done to eliminate those people? And number 2, what has been done to employ people who are qualified to lead institutions instead of cater deployment?
Thank you. Then next, okay.
Thank you. I like to thank on all the speakers. My question is on quality. As Dr. Asaman has showed us that there's a problem of quality on our staff or of the health workers. So my question is on Dr. Pesi and Dr. Baeni. I just want to know what strategies are you having in place to ensure that healthy workers, both who are in system for the long time, because it does not mean if you've been long in the system you are competent, and the new workers, to ensure that they are on the same level of competency, and what plans are you having for the institutions that are training these healthy workers to ensure that at the exit level, they have same level of competency. There's no institution that is, say, someone who's trained in WSU is better from the other institution. And this quality has put our country in a lot of negligence and litigations. And if you look at the budget, it's a lot of billions that are going for litigations. I just want to know, after your audit as the department, what strategies have you put in place to ensure that the audit are put in place, the strategies that we identify in audit are put in place so that we won't lose this money, because these billions can be used to hire a lot of health workers who are unemployed. Thank you.
Thank you. The last two questions.
Good afternoon. My name is Sivuile Mange. I'm from Umtata Regional Hospital. In appreciating all the presentations that are so informative, I've got some concerns that I want to register. We talk of universal health coverage, of which that is NHI in the South African context as a funding model, of which the approach in realizing that is the primary health care, which is less expensive than curative. So my first concern, we have community healthcare workers that are believed to be cadres that are needed at primary healthcare level in strengthening the primary healthcare approach that are still to be put in the system so that they are permanently employed. That's the first concern. And we know that NHI is about access to quality healthcare service. For that, we need resources. We have aging workforce, and that means we are going to lose them soon, especially the specialists. In the province, as we speak, we are sitting with a challenge of not producing specialist nurses for 3 consecutive years due to prolonged process of accrediting nursing education institution to offer these programs. Also, the implications of austerity measures in developing e-structure as a department, because the structure should be aligned to e-budget, not on the needs on the ground. Therefore, the issue of e-recruitment and retention, balancing it with the service delivery mandate, remains a big challenge if the Department of Health can't be exempted from austerity measures implemented by National Treasury. Also, the issue of upskilling the workforce to meet the changing times. We talk of fourth industrial revolution and AI, of which we need to adapt and not to be resistant to change. The last part is the issue of e-brain drain. Seemingly, we are still having a challenge that needs to be addressed in terms of e-brain drain. Thank you so much.
Thank you, Chad. The last one now. At the back. Oh, I've seen another, the real last.
Ncebakazi Galata is my
Dr.
name.
Makola and the last one at the back. Only no more again.
Thank you, ma'am. I'm from the Township Cannabis Incubator. I think my question is for Dr. Samani and also for Dr. Mahlati. I think there was a comment that was made on the private sector, because what seems to be obvious is that our health system is highly burdened. And I want to get an understanding whether has the department considered skilling our doctors, as I think it was indicated that if there are no opportunities in the public sector, it should not take them long for them to wait for that training in the public service before they can go open their own practices. Because I believe that if we could provide that support, that as soon as they are able to graduate, there is that private sector entrepreneurship support for them to start their own practices. My second question is on how, also from the WHO, Dr. Asamani, how is the WHO organization embracing the indigenous knowledge systems in tackling the health burden in Africa? Because I'm thinking that some of the solutions can also come from those traditional health practices so that we ease that overburdening of our public sector, matching that with the integration with the private support. So if perhaps we can maybe have an engagement on that, we'll appreciate.
Okay. The hand there, then last Dr. Makola, please.
Yes, so Dr. Bayani spoke to the 2030 HRH strategic goals. One being effective workforce planning. I just want to check what's been your assessment or progress made in that aspect, given recurrent challenges facing the sector. For instance, that of having yearly strikes at the beginning of the year, because already you know that you train and there's ComServe, doctors, nurses, pharmacists who would need to be employed, especially in the public space. There's been reasons mentioned. I won't go over them again as to why they need to be retained by the public sector. What ways or answers have been there to effect this goal number one or as you said? Thank you.
The last question, please. Okay.
No, thank you very much. Dr. Magula from Public Health. I just want to, the question to Dr. Mahlati and Dr. Bain. Taking note of the fact that we have a 60 billion rand shortfall in the coming financial year. I'm just, trying to find out from your comment in terms of how are the provinces potentially preparing themselves, because I think with that type of shortfall, there's definitely a likelihood that we are going to have a cut in the budget that becomes available for healthcare services. I'm just wondering as to whether, from a health workforce point of view, are you in any way interacting with provinces to make sure that they can start making the necessary adjustments and also planning in the context of that, realization that we are likely to face, cuts in the short to medium term. Thanks.
Thank you so much. Now okay. Dr. Pierce want to talk first.
Yeah, because I want to take a few easy ones. The difficult ones I will leave for Luvuyo. Let me start with the one about doctors going into the private sector to set up their rooms. I think it would be fair to select doctors and say they must be assisted to set up their private practices, whilst nobody else is actually getting that. That's the space of entrepreneurship. I say that because for 10 years I was in private practice. You go and raise a loan, you take the risk, and you make sure that you are going to pay that loan back. Simple. Physiotherapists go to private practice. They can't expect that because they're not absorbed in government. Therefore, government must give them money to set up private practice. That is why I raised that issue in the pamphlet. Say that to some extent as medical professionals, there's some siege mentality. We feel we're under siege. We're not. We're not, colleagues. And there is no guarantee that if you are educated, supported by the state, that even when the state is undergoing serious problems, it must be obliged to be tied to support professionals. Colleagues, there are people who are so poor that they actually need to be supported by the state. There I come as a medical doctor, I say, no, prioritize me, leave those ones. No, we can't, colleagues. It's about values. That is what it is about. I know that I will be cut to pieces for what I'm saying. Like I said earlier, I say it as I feel it. Maybe the age is allowing me to say so, and the experience. So that one, colleagues, even if you were to raise it, I would never support it. You actually take the risk yourself. Because the profits that you are going to make, you are not going to share even with the patients. That we know. We may say something else in public, but in private, we know what we do. Let me come to the next one. Accreditation of nursing programs at WSU. Slow process, but that slow process was produced by WSU itself. I will not go into detail, but I know very well. about the accreditation of what we call PGDips, postgraduate diplomas in nursing. There were universities that actually sprang to actually put up their programs. WSU was one of those that was almost last in the process. So it's the internal processes that actually led to that. And by the way, something that we shared with your dean was that the divisions in nursing, you've got nursing at WSU and you've got Lilita College, they're not sharing any strategic vision. Those are some of the problems that we actually have to deal with. If it has been resolved, that would be great, you know, and would be very, very happy. Let me get to the second last. Colleagues, let's not confuse universal health coverage with National Health Insurance Fund or scheme. Those two things are not the same. You use the other to achieve the other. You actually use a better funding mechanism to achieve universal health coverage. Those two are not interchangeable. I know that communication sometimes has been that, you know, where it's as if they're the same. You actually use better mechanisms of funding to be able to achieve coverage. But like Professor Mani said, the fact that you've got, you know, extensive, even 100% coverage doesn't mean that you've got quality. So there are various levels in there that you actually have to look at. Employing qualified people, it starts with leadership. 2023, we actually revamped a framework for governance and leadership, and we started with central hospitals like this one. 10 of them in the country that did not have, I mean, we've got 10 and 6 of them did not have leadership. It's unfortunate that the only central hospital that did the right thing was Groote. All others did not. And all others are not in the Western Cape. So we are because if you don't have the right kind of leadership right at the top, what kind of agenda are you going to set? But unfortunately, these are some of the issues that are above, you know, even my pay grade, you know. And I think others I'll leave to Dr. Bayeni to tackle.
Thank you, Doc.
Thank you very much. And it doesn't mean my pay grade is above his. Mine is even lower. So you can imagine how will I respond to some of them. Thank you very much. I think if maybe just to supplement the last one, the first 3 slides on leadership were actually taken from a presentation that was trying to talk to what caliber requirements that do we want for central hospitals. So that actually is part of the presentation that we did. So there is an intention from national. However, there are sometimes limitations that we don't run provinces. And some of the facilities then fall under provincial recruitment processes. The first one, clinical associates, an update, which is very exciting. Indeed, there has been a concern as to where does the department stand and what is the future of the clinical associates from a National Department of Health position. We opted that we don't want to use sentiments, we don't want to use influence from people, and that process has now been officially allocated for a program review, and the work is commissioned and it's going to be assisted by Health Systems Trust. So what that means is that there would be some work that will be done independent of us to go around the 3 facilities that are offering clinical associates, to interview the graduates from clinical associates program, as well as the facilities that have been placing clinical associates, to get a sense as to how then do we move forward in terms of the program. The new minister is awaiting that to inform what then becomes the agenda or the political position of the Department on Clinical Associates. So finally, we have managed to secure that support, so it will be undergoing that. Uboss ubalekile accountability and corruption. Okay. No, I think colleagues, there is work from our side depending on what falls on our lap. The issue and the work we are doing on committed overtime, to me, talks to the very same thing of accountability and corruption. We've got facilities and institutions where doctors know that they have been getting paid for overtime, but they've never been even called out at night. And we are trying to correct that. So part of the committed overtime management plan that is in place is to try and improve on accountability. We're not saying that you are going to work for free for government, but we are saying we must pay you for having worked for government. And if you have not worked, we can't be paying you, unfortunately. We don't have that luxury and money anymore. If besinayo, maybe besizavala mehlo, but there is no money anymore. So there is work on the spheres of the committed overtime accountability issue. And of course, we do expect that other issues that relate to corruption will be handled by the corruption agencies. Audit recommendations and what are we doing about those. The slide on strengthening clinical governance is what we are trying to remind. I think there was a bullet there that was saying we are even reminding that clinical audits are compulsory on a monthly basis at facilities. Because apart from just wanting to find the recommendations, there is a widespread lull in terms of the actual clinical audits taking place. So even if you were to say you want to act on the recommendations, some facilities don't even host and convene those clinical audits. So on the leadership, on clinical governance, it's what we are raising. And our message is clear that some of the issues that are costing us, we have been too quick to push them to a side. We say it's medical legal, we say legal must deal with it. Or we would say it's a question of maternal, we say maternal must deal with it. Whereas they could be better prevented if there was a strong clinical governance. And clinical governance is the one that is supposed to run and make sure that these audits take place, there are recommendations, there are improvement plans. So for us, if we could work with each other and improve on clinical governance issues, that will help us. What we're doing from a national point of view is to try and see how can we skill and support clinical managers and clinical governance. So we are in talks with the National School of Governance to say some of the courses they offer, yes, they are available to public servants, but we feel we want to input that they can at least be tailor-made for the clinical setup in the health sector. So there is that work that we are doing to ensure that at least we can capacitate. Employment of community health workers. Yes, it came back from court last week. It's in the hands of the minister and review and consultation with the treasurer. So the leader of the nursing fraternity there, he knows exactly what he's asking. The minister will announce how we are going to respond to that order from the court that you are referring to. But we can safely commend colleagues that he has also expressed that the system needs healthcare workers. So it's just a question of the modalities as to how do we make use of them. We are not disputing that there is a value add and a role for them in terms of the delivering healthcare system in the country. The departmental structure, provinces are reporting different stages, but it's something that is a bit of a frustration for us. Because when we look across provinces, it seems as if officially most provinces are using 2012, 2008 structures, but when they report, they will tell you that, no, we got one that was approved, but we got one that is awaiting OTP. For Eastern Cape, we are in talking with DPSA and the Office of the Premier to see what progress has been made in terms of finalizing that work. So our support from national is to support provinces, but unfortunately, we can't interfere and impose. But we're working with DPSA to try and assist us into ensuring that at least some work is done. But it's true that there are frustrations that some of the structures are trying to lean towards budget over and above the need. And actually, we should be trying by identifying first what is the need and what we want to achieve before worrying about the budget. And thereafter, the presentation we did that financing must also respond to what we want to achieve, even if it might be difficult to fund everything. Budget shortfalls. In last week's meeting that we were having with DHET, we had invited my counterpart, Chief Director from Treasury, who deals with health financing, a certain famous Dr. Mark Bletch. He said to us, the meeting was on Tuesday before the budget speech that was postponed. He said, I can't talk about budget because things are in the budget speech and I don't know what is gonna be said by the minister, even if I know. So there was that risk already we sensed last week that what we might hear might not be good news. The budget speech was postponed, but I am told today that provinces have been notified what their budget status is, and unfortunately it will be provincial arrangements as to how that is catered into. If you come close to home, Eastern Cape, Treasury has already returned to Eastern Cape Department of Health to say, this is how your budget is going to look like, and there are areas where they are saying, we expect you to come with answers. One of them is got to do with committed overtime. I know tomorrow the department is having a meeting on that, which we'll participate in. So there is an indication as to there are things that must be done differently to accommodate the limited budget that is there. And I suppose the same thing will happen, that we might have to wait and hear by the MEC speech in terms of where are we going to feel the pinch and what else is going to happen. I think I've covered most of them. But just to maybe share them or alleviate fears, there is a consideration to say, whilst our professionals are undergoing internship and training, how can we assist them with the skilling of entrepreneurship? Not necessarily to fund. So there is that consideration that whether through a webinar or something, just some capacitation to say, as much as you are now undergoing internship and community service, should you intend to open a spaza shop, please look at these parameters, including going for a loan, including committing and taking the risk and whatever. So we are intending, from the ICSP point of view, to say, how can we enhance the program of placements as they are in the program of community service, if we cannot empower them through some service provider or some webinars, so that if someone is to consider, at least they are enlightened, because we know at undergrad currently there is nothing that goes close to entrepreneurship for healthcare workers. So we're gonna see if we cannot try and impact that skill during the community service placements. Thank you.
Thank you, Doc. Prof, about the comment on cancer care.
Yes, I won't be long. Thank you for the question about the transportation and other costs. And unfortunately, there aren't many insurance programs around the world that cover those sorts of costs. Although we know from the limited studies that have been done that those costs can be quite crippling and prevent people from accessing care. The one exception I can think of is health equity funds in Cambodia, which is an experiment there to reimburse, at least in part, some of the transport costs that people experience when they go to hospital. I think it's tempting in a resource-constrained environment to think, well, those costs are probably not going to be affordable by government to cover. It's probably something one step too far. But, you know, for cancer care, particularly for early treatment and screening, there may be a strong economic case for doing that. If it's getting people to the clinic and getting them early, you're potentially saving costs further down the line. So there is a research question there that can be looked at, and it's potentially something that we could look into in that study that we talked about. But thank you for the question.
Yes, I think the questions that were directed to me were largely answered by Dr. Percy and the other colleagues. So I would just comment on the last one around whether WHO is considering to embrace indigenous medicine to address workforce shortages. Yes, indeed, indigenous medicine has been with us and they've played their role thus far. And going forward, it's not a question of if, it is a question of how we do it to use their potential to mitigate the workforce shortages that we are seeing. And to do so, the first thing to do is to understand who are they and what do they do. So that understanding of who are they and what do they do would allow us to see who exactly is doing what at where and how they have acquired their knowledge, and whether that knowledge, not all of them have their knowledge is consistent with what we know is safe practices. So who among them need their knowledge to be updated and all of that. So some work has already started at the global level, trying to review the status of, we call them traditional and complementary medicine, the work of traditional and complementary medicine practitioners. And so that work is ongoing. When it's completed, the next logical step is to have more discussion around it, to now think about having a framework to potentially regulate their practice so that there can also be accountability, but also come up with standardized curricula to more or less integrate their work more into the health system. For those that are trained at very reasonable levels, I know in some countries they are employed even by the public sector, and you go to a clinic and they will tell you, okay, your situation can be dealt by a normal doctor or a traditional doctor. So you choose where you want to go, and they actually refer cases to each other. So sometimes a doctor look at you and realize that they've done everything. The rest of it is, you need somebody who can speak the language you understand, and they refer you to a traditional person. Sometimes the traditional doctor also look at you and say, this one, you need a clinical doctor, and they refer you. So a few countries are doing so, but there's not been formal evaluation to see how effective it has been. Maybe that is one of the things that going forward we need to also think about, learning those lessons and helping others who may want to adopt it. Yeah, thank you so much.
I did know you're going to do it, but it is very little. It can be bigger, please. Thank you so much. Those hands were for our presenters. They've done it very well. We are well informed now. We can go and practice some of what has been said here. Now I would like you to give some more hands for the audience. You had a very good audience who was listening, who participated and engaged the presenters. Your hands, please. Thank you. Now it's lunchtime, and the time is 3 o'clock. Is that true? It's 5 past, it's 4 minutes. I'll tell now. It's 4 minutes past 3, and we are going to be back here at 3:30 to catch up with little that has been left. Then you can go home after that. Thank you so much.
But there's a line that talks about community. Yes.
Yeah.